Namaste everyone. Welcome to the online course of BNB knee course. In the series, many of my colleagues have presented very interesting topics, and the discussion was very interesting. So this is my turn to present you on the topic which names as how to read an MRI. So in my practice for last 12 years, I've started reading my MRI by myself, and that has increased the sensitivity of MRI to detect a particular disease of the knee joint. Why I prefer reading by the clinicians the MRI is because we have a clinical values also. We have examined the patient, we know what is his clinical findings are, and then based upon that clinical findings, we do a meticulous study or meticulous reading of that particular structure into the MRI that will increase the sensitivity of the MRI. There are various ways of reading MRI. If you go to YouTube or go to ViewMedi, you will find out an elaborated reading of MRI. But this MRI reading was done by the radiologist. When they have a workstation, they have a smaller card, they can rotate it, they can tilt it and do it. Unfortunately, this facility is not available with the clinician. So clinician has to decide or read MRI based upon the film they are provided to us. What is important to understand that the radiologists give us the film which has more positive finding than the negative findings. That is why these concise films, say about 5-6 films, are the summary of the so many cuts that has been read by the radiologist. So this has most valuable points and most valuable records. So when we get an MRI in our OPD, so I take out the film and try to see the films. So this is our sagittal section film. This is our axial film. This is our coronal film. And then I have one more sagittal film and then one more sagittal film. So what I do is I put them into the sequence. So this is sagittal film, this is another, and this is another. So 3 sagittal film, 1 coronal film, and then 1 axial film. And this is the sequence in which I read my MRI. I first see the sagittal film, and then I see the coronal film, and then I see the axial film. Okay, here I have put all the 3 films of sagittal section that was provided to us by the radiologist. So this film is a T2 image, this film is the T1 image, and this one is the fat sat image, that extra image the radiologist gave to us. So in the sagittal section we see 5 things. We see 5 things. One is the extensor mechanism, that is the quadriceps tendon and the patellar tendon. In the extensor mechanism, we also see the patella. Then we see the menisci. Then we see axial and the PCL. So these are the structures that we see in the sagittal region. Also in this case, we can see the effusion as well as the cartilage. So I always start from looking at the quadriceps mechanism. You can see that this is the quadriceps, this is the patella. You can see the patella has a good cartilage out here. You continue the cartilage. The patellar cartilage is normal out there, and the patellar cartilage is normal. Then you see the patellar tendon out here. This is the patellar tendon, this is patellar tendon. You can see the patellar tendon in various sequences of the patellar tendon. Very missed things in the quadriceps mechanism is either it's a patella alta or patellar baja. Also some injury to the quadriceps and the patellar tendon and some cartilage defect of the patella, which is very important to see when you see the extensor mechanism. Next structure we see is the meniscus. Meniscus is very important to identify. Either we are looking at the lateral meniscus or the medial meniscus. So identify either it is a lateral cut or is the medial cut. There are various stuff, but very important is the fibular head. You can also identify the lateral tibial plateau by a convexity of the tibial plateau. You can see that this is the convex tibial plateau, this is the concave tibial plateau. So convex tibial plateau is because of the lateral condyle, and the convex is lateral condyle, and the concave is the medial condyle. So in this case, the cuts are coming from the lateral to the medial side. So that is why in the lateral side, since there is a fibular head is present, you start seeing the meniscus. So this is the body of the meniscus. Again, this is the body of the meniscus. Going towards the medial, we will find out that this is the posterior horn of the meniscus. This is the anterior horn of the meniscus. When you continue seeing this meniscus, then it becomes a bow tie appearance. So this is the anterior horn, this is posterior horn, this is anterior, this is posterior, this is anterior horn, and the posterior horn you can see. So once the horn finishes, then starts the notch. So in notch area there is no meniscus, rather we'll see the ACL and PCL. I will not go into the ACL and PCL at this moment. I cross this notch area and go across and find out that then starts the medial meniscus. So this is the medial compartment now. You can see the medial compartment also by the concavity of the tibial condyle or tibial plateau, and you can see that this is the anterior horn of the meniscus. This is posterior horn, anterior posterior, anterior posterior, anterior posterior, anterior posterior, anterior. So meniscus looks, both the menisci look normal. What is important to understand that these meniscal tear has been, by the radiologists, has been classified variously. They can say it either it's a grade 1, grade 2 or grade 3. What is important is grade 1 and grade 2 are not a tear, these are the intra-substance degeneration. So only the lucent area which is available in the body of the meniscus or in the meniscus, unless it goes into the articular margins, either the inferior or superior, they cannot be considered as a meniscal tear. If the tear is well within the meniscal tissue, they are known as a degenerative meniscus. So the same thing I confirm in the other views. In the other views that the meniscus are okay and the patellar tendon and everything is okay, and then you confirm the other thing also. So after the meniscus, I see the ACL and the PCL, which is very important to identify in the sagittal section. Now you know that this films is coming from the lateral condyle to the medial condyle. So that is important fact we have to know, because we need to identify where is the ACL. So since it is coming from the lateral condyle to the medial condyle, we know that ACL is attached into the medial border of the lateral condyle. So in this particular case, the ACL comes first and then the PCL comes the next one. So when we go into the cross the meniscus, then it starts the notch area. So you can see here the ACL, the fibers of the ACL going right back. So it is very important when we see the ACL, we have to measure the angle of inclination, that is called ACL Blumenstadt line. So ACL Blumenstadt line has to close into the femoral area. If you draw imaginary line into Blumenstadt and the ACL, then it closes into the femoral area. I have a separate MRI to show to that. We'll when we'll come next on that one. So here you can see the ACL is intact. This ACL is intact. You can see it reaching right up to the femoral condyle. So after the ACL, then starts the PCL. So this is some part of the PCL, and this one whole looks like a PCL. So in this case, you can see the wavy PCL. The PCL is wavy. So the wavy PCL indicates that there is a ACL tear and there is a subluxation of the tibia. So in this case, you can see the wavy PCL, and then the PCL is not visualized in this case. So same thing we confirm in the other views. We can see here, this is the PCL, this is the PCL that we can clearly see, and the ACL can also be seen in this one. If you see the fat sac, which is very important, you can see in this slide the ACL is running right from the tibial attachment to the femoral attachment, and the angle of Blumenstadt ACL angle is going right about there, and the PCL looks very normal in this case. You can see that this is PCL. So sagittal images are very important. In sagittal image, we see the quadriceps mechanism, we see the patellar cartilage, then we see the meniscus, and we see ACL and the PCL. Sometimes it is worthwhile finding the cartilage. And to read the cartilage, it is better to have a fat sac image. Let me change this, bring this image near to me. and try to see the fac-sat image. So this is a fac-sat image, and in which you can see that the cartilage, the tibial cartilage is this, which looks a little dark, and it should be darker. So this is a femoral cartilage, and this is the tibial cartilage. So any defect in the femoral cartilage or in the tibial cartilage, you can see that these black spots are the tibial cartilage. This is your femoral cartilage. So if there is a cartilage defect, it can be detected in this sagittal view as well. So now we are done with the sagittal view. Now we will go to the coronal view. So in coronal view, again, we don't see all the things. Now in this view, we confirm the findings that we had in the sagittal view. So in coronal view, you can see that this is patella. This is patella. So that means the cuts are coming from anterior to posterior, and this is the posterior condyle. So in coronal view, we can see the patella as well as the quadriceps mechanism. So this is the quadriceps tendon, and this is the patellar tendon. And sometimes you can find some osteophytes or Sinding-Larsen-Jansen's disease in this coronal section as well. Very important to see in the coronal section is medial collateral ligament, lateral collateral ligament, and the cartilage has to be seen very meticulously in this one. So to see the medial collateral ligament, you trace the femur. This is the anterior part of the femur. Then we are coming to the epicondyle. The epicondyle is since little posteriorly, the MCL will be visible in little posterior. So this is the epicondyle, medial epicondyle, and you can see a very nicely visible medial collateral ligament in this one. Now we have to know that medial collateral ligament has a deep and superficial part. So this is the deep part, this is the medial collateral ligament coming and attaching into the right 2 mm below the joint line. This is the deep medial collateral ligament, and this is the superficial collateral ligament, which goes way beyond about 8 cm below the tibial plateau or tibial joint line. So this is the medial collateral ligament, which is superficial medial collateral ligament, which is going way below the joint. Now looking at the lateral collateral ligament, if you know how to identify the lateral collateral ligament, it is very easy. So to identify the lateral collateral ligament, you have to identify a chin of a human, or it is also known as a human face. So if you see the wavy structure out here, this is forming a human face. So this is the chin, this is lips, and this is nose, and somewhere up there is the forehead. So the lateral collateral ligament starts right from the face of this human face. So this is the human face, and this, what is starting from that one, is the lateral collateral ligament. You can see that this is the lateral collateral ligament. Since the course of the lateral collateral ligament is from the anterior to posterior, sometimes it is not visible in toto. So this is the starting of the lateral collateral ligament. If you follow that, you can see there the lateral collateral ligament goes all the way to the head of the fibula. So this is the lateral collateral ligament. And in this case, the lateral collateral ligament is also intact. Medial collateral ligament is also very intact in this particular case. In the sagittal section, another thing that is very important to read is the cartilage. So if you see that this is the femur, this is the black structure is the femoral cartilage. Here also this is the femoral cartilage. You can see the femoral cartilage out here and the tibial cartilage out there. You can continue watching that, the femoral cartilage and the tibial cartilage. So any cartilage defect will be more visible in this coronal section. Another thing very important to see in this one is the meniscus. So in this case, we will not see meniscus as a anterior and posterior horn. We will see both the menisci, both the part of the menisci at the same time. So if you see here, the medial meniscus is already visualized here, but the lateral meniscus is not visualized because of the obliquity. But you can trace this meniscus. So this is the meniscus, this is meniscus, the meniscus looks normal, and the medial meniscus out here is very perfectly normal in all the parts. What is important to see in this view is the root. So you see that this is the meniscus, and the meniscus goes down. The medial part of the meniscus goes down. That is, this is the root. You see that the root, it is coming down. So always the medial edge of the meniscus has to go down rather than up. In case of the medial meniscus also, if you see that the medial meniscus and its root is also coming down. So here also if you see that this is the medial meniscus, root is coming down, and these fibers are known as the intermeniscal fibers. Sometimes these intermeniscal fibers are also very important. So in this case, you can see both the medial and the lateral meniscus, and important in the meniscus is the root. So you have to identify where is the root of the meniscus. So root always goes down to the notch. So after that, the final section is the axial section. So I put this axial cuts into the view box. In the axial cut, it is very important to see the patella, the patellar cartilage, and the femoral cartilage, and these are the things that is very much visible. Also, if the T2 image is available, you can see the fluid. Since this is a T1 image, you can see that this whole thing is fluid in the joint, so it indicates that patient is having a effusion. Then you can see that this all is the cartilage part, femoral cartilage. The patella hasn't appeared yet. Now its patella starts appearing. So this is the superior part of the patella. You can see the cartilage thick and nice, no signal changes. The patellar cartilage, femoral cartilage, a little bit of signal changes in the femur, this one, like kind of fissuring here. You can see a little bit of fissuring, but the cartilage looks normal as of the femoral cartilage as well as the tibial cartilage. So the axial cut is basically for the detection of any cartilage defect into the patella or in the femur. So this completes my reading of the normal MRI. Now I'd like to show you some abnormal MRI that I have collected for this discussion purpose. So this is an MRI of a patient who had a ACL tear. I just brought this MRI film to see to verify or to explain what is the Blumensack ACL or ACL Blumensack line angle. So if you see that this is the MRI, the sequence of reading is the same. You read extensor mechanism first, then the meniscus, and then the ACL, PCL, and the cartilage. So here, if you focus into this one, Vijendra, are you focusing it?
Yes, sir.
Yeah. So focus into this one. This is very nicely drawn by my fellow Dr. Vijendra Adhikari. So now here, this line goes from the Blumensack line, and this is the central axis of the ACL. So you can see that the ACL angle is not going towards the Blumensack line. Though most of this ACL is visible out here, but this ACL is going down. So the apex of the angle is not in the femur, it is in the tibia. Ideally, it has to be in the femur. So this indicates that in this MRI, the radiologist has reported a partial ACL tear because most of the ACL is visible out here. Actually, this is not an ACL, this is the remnant of the ACL. It has been torn from the femoral side and gone down. That is why it is lying horizontally. So this is very important for colleagues. I want to emphasize on this one that we always should measure whenever there is a visible stump of the ACL and the diagnosis is partial tear. We should always measure this Blumensack ACL line to identify, and it has to close into ACL has to go acute into the Blumensack line. In this case, it is not acute, it is going down. That means the patient is having a ACL tear. Case in which you can see that the ACL is intact. If you see this ACL, this is the ACL of the patient, and ACL is intact because if you draw the line that we were discussing, the Blumensack line and the ACL line, this is closing into the femoral side. So this is an acute angle. This is an acute angle to the Blumensack line. That means the ACL is intact. If you trace to the PCL, you will find out that PCL is wavy, and there is a tear of the PCL. This is more visible in this one. If you see that here, can you focus here, Vijendra?
Yes,
so this is the proximal part of the PCL, which is not in continuous with the distal part. So this is the PCL, it is not continuous. So this is a case of isolated PCL injury, which is very rare in these kind of patients. Okay, next, as I said, the MCL starts from the medial epicondyle. Probably this is the MCL, medial epicondyle, from where the MCL starts. This is the MCL, but you can see the edema around it. the edema around it, but the MCL looks pretty okay. See that? The MCL is going all the way down to the tibia. So MCL is okay, however there is an edema. So this edema, whenever we see this edema around the MCL, we have to be very suspicious and have to trace the MCL all the way down to detect any pathology. In this case, although there is an edema, the MCL looks intact. Similarly, as I told that we have to find out the face of the human. This is the face of the human. And you can see that the LCL starts from here. Since the LCL starts from here, it doesn't come in down, there is an edema here, and then probably the patient is having an LCL injury in this case. You can see that this is the lateral collateral ligament which doesn't go in continuous with the fibula. In this case also you can see there are a lot of edema. There is a wavy type of the LCL which is indicating that there is probably a LCL injury. So it is important when you read the MRI and trying to identify the integrity of the MCL and LCL, we have to look at the edema. So you can see that there is less of the edema on the medial side, more of the edema on the lateral side, and this patient had a lateral collateral ligament tear. So this is another case, and now we are looking at the meniscus. Since this is again from the lateral to medial side, we start visualizing the lateral meniscus. This is the body, peripheral body. Then you start having a bow tie appearance of the lateral meniscus. You continue with the posterior horn, anterior horn of the lateral meniscus. You can see the fibular head, that also indicates the dome shape of the tibia, also indicates that this is the lateral condyle. The posterior horn, anterior horn, posterior horn, anterior horn, posterior anterior, then posterior horn, and probably this is the root posterior horn. You can see also ACL very nicely out there. It is well angulated to the Blumenset line. You can see the PCL, which indicates that this is in the notch. So this is PCL, and then we go into the medial meniscus or the medial compartment. Right away in the middle part, right at the root area, you can see that there is a horizontal split of the meniscus. You see that? This is the meniscus. The meniscus actually should be a triangular shape, but you can see a linear hypersignal intensity going right across the meniscus, and it is coming to the inferior joint line. So this indicates that this is a clear-cut meniscal tear. You can see that this is the shape of the meniscus, the hypersignal intensity is there, which indicates the meniscal tear. So patient is having a posterior horn extending up to the, from if it is 5 mm, then you start 5, 10, 15, maybe 22 centimeter from the root of this one. So there is a horizontal tear of the meniscus. The same patient, if you see here in the coronal section, you start seeing in the posterior part of the meniscus, the horizontal tear of the meniscus. This whole thing is the substance of the meniscus. This is the root of the meniscus, as you see that it's going downwards. This is the root of the meniscus. This is the root of the lateral meniscus. But you see in the medial meniscus, there is a signal intensity change, and it is going into the articular surface, which indicates that this is a horizontal tear of the medial meniscus. Again, the sagittal section, and you can see in the sagittal section same thing, but we are not going to read on to that. We are trying to see this structure. If you see this, there is one PCL-like structure and there is another PCL-like structure. See, one PCL-like structure and another PCL-like structure. So this is called as a double PCL sign. So double PCL sign is indicative of displaced bucket handle tear of the medial meniscus, and this is very classic for the medial meniscus tear, and it is displaced bucket handle tear. So there is one PCL and there is another PCL. So this is called the double PCL sign of bucket handle tear of the medial meniscus. So up to very recent, we used to neglect, and we did not focus in the root tears. But very recently, we understood that root tears are very important, and root tear is as good as total meniscectomy. So more emphasis is focused nowadays on the root tears. So this is a case of a patient who had a ACL tear. Now you can see that the ACL is not very well visualized, but the PCL is very nice seen out here. So this is a case of ACL, and then while looking at the coronal section, we found out that you see very carefully and meticulously the root of the medial meniscus is torn out here. So the root has to go right up to there and go down, but you can see that the root of the meniscus is torn in this place. Although this patient doesn't show a ghost sign in its sagittal section or in the coronal section, but you can see that there is a clear-cut indication of root tear in this one. And if you retrospectively see that the location of the meniscus, you see that this is the meniscus, this has extruded, this is outside the condyle. See that the extruded or the subluxed meniscus or lateralized meniscus in compared to the other meniscus is indicative of a root tear as well. If you see there, this is extruded. If you see here, it's very clearly visualized that the meniscus has shifted or lateralized. And then you can see that there is a continuity loss of the medial meniscus. Ideally, it has to go literally down like this, but there is a loss of continuity, which indicates that there is a root tear of the medial meniscus.